Okay, well, I'll just maybe briefly introduce you in case there are any outside people on the call. It's really nice to have everyone together for our updates and advances in GU oncology. We're very lucky tonight to have Dr. VanderWeele. Dr. VanderWeele is one of our genitourinary oncology experts here at Northwestern. He's also the GU lead in the early phase therapeutics clinic. He's a oncologist and a scientist, and he pairs those two together with multiple trials that he's running with biomarkers, selected individuals, as well as research that spans prostate, bladder, and testicular cancers. Yeah, as I was mentioning, GU ASCO was really great. I really enjoyed, particularly Dr. VanderWeele's session. He's going to talk about highlights of GU ASCO tonight. I'll turn it over to you, David, and thanks again for doing this.
Thanks, Ash. It was kind of exciting, GU ASCO, especially if you're kind of prostate focused. And I was involved with the oral abstract session, which generated some controversy during the session and afterwards, and in the Twitter world a little bit. So this talk actually will be heavily weighted in that direction, just because I think that was where some of the more interesting data was presented. But here's the outline. So we'll talk about prostate, bladder, and kidney, but more under the prostate. ARASENS is the one that I think is the practice-changing study. And then PROpel and MAGNITUDE, similar studies, sort of in the same space, sort of competing studies, although they did have different designs and a little different outcomes. So that's really what generated the interest. And then just a slide or two, something interesting from therapy, something that I'm kind of interested in. So by no means practice changing, but something of interest to me. And then touching on a few things in bladder, particularly with the antibody drug conjugates. So one with enfortumab vedotin, another one with sacituzumab govitecan. Those are our newest agents approved for bladder. And then briefly, one study for kidney as well. All right. So ARASENS, this actually, Dr. Hussein was involved with this study, and we had it open here while it was going on. So this is for metastatic hormone-sensitive prostate cancer, good performance status, candidates for ADT and docetaxel. And then randomized to either ADT, docetaxel, and placebo, or ADT, docetaxel, and darolutamide. Like charted, you get 6 cycles of chemotherapy and then continue on your other therapy until progression. And here, I feel like we're seeing this less and less, but the primary endpoint was overall survival. And so looking at the patients who were enrolled in this study, the vast majority were M1 and outright metastatic at the time of diagnosis, and so not recurrent, but de novo metastatic. In addition, most people were not just metastatic to the pelvic nodes, but had more widespread metastatic disease. So these are things that you would expect for patients getting ADT and docetaxel, although really this trial was designed before we had like Latitude and Stampede with abiraterone available. So it was not restricted just to those with high volume disease. And so here is the castrate time to, no, so this is progression-free survival, or radiographic progression-free survival. And very nice separation of the curves here for those getting darolutamide as opposed to those continuing on just ADT alone plus placebo, with a hazard ratio of 0.36. These are curves that, of course, we like to see, but we don't see all that often. So this is progression-free survival, and this did translate into an overall survival benefit as well. The data still are not that mature. We don't have a median overall survival for the darolutamide arm, but still the hazard ratio is 0.68. So now So that's great. That's a decent separation between the curves. It's a good hazard ratio for us for overall survival. Looking at the beginning of diagnosis and treating for all those years afterwards, you still see a survival benefit that can be difficult to achieve these days. What about subsequent therapies? Are we looking at patients who got darolutamide up front or did not get darolutamide at all or didn't get any other AR pathway inhibitor at all? Well, that doesn't seem to be the case. So patients on the placebo arm, 76% of them got some subsequent life-prolonging therapy. And for many of them, that was 75% ABI or enzalutamide, a handful with apalutamide. Darolutamide, of course, is only approved for non-metastatic CRPC, so not included in this list for subsequent therapy. And what about safety? If we're going from doublet to triplet therapy, what does the safety look like? Actually quite good. So not very different, not very large differences in these numbers between those receiving the triplet with darolutamide and those getting just ADT and docetaxel alone. They also presented this kind of time adjusted because, of course, patients were on darolutamide much longer, and then the safety looks even more impressive. But really, this is very reassuring in terms of a safety profile. No worsening of docetaxel-related toxicities, and in general, tolerating the darolutamide quite well. So conclusions and questions from ARASENS. So chemotherapy plus an AR pathway inhibitor is safe and effective. And I do think that this should be considered the new standard of care for patients with aggressive metastatic hormone-sensitive prostate cancer. And of course, this is coming on the heels of PEACE-1, which presented their initial data at ASCO last year, I believe, and then updated with overall survival data at ESMO. And they also showed an improvement in overall survival, but really this is more impressive on the safety side, more impressive on the overall survival benefit. So I'd say, there's separate trials and individual populations. Of course, we shouldn't be comparing them, but that being said, we often do. But darolutamide and docetaxel appears to be as safe and effective as abiraterone and docetaxel. Of course, adding darolutamide also makes it more expensive. But the data, so one, I think darolutamide is certainly an option. I don't know that it's necessarily the better option than abiraterone and prednisone, but it certainly is an option for those for whom you may be concerned about side effects from ABI. The data really are pretty impressive, I think, both safety and efficacy. And now with the second large phase 3 study showing the benefit of an AR pathway inhibitor plus docetaxel, I think that this really should be the new standard of care for those getting docetaxel. So then the question is, who needs the docetaxel, or do we need the docetaxel? Of course, both of these large phase 3 studies were designed early on after CHARTED and the initial STAMPEDE evaluation of docetaxel. And so everybody got ADT and docetaxel, and then the question is, do you need the AR pathway inhibitor? We don't know the data. We don't know the answer to, do you need the docetaxel? But certainly for those for whom you're thinking about giving docetaxel, I think it makes sense to be adding on an AR pathway inhibitor. And, I also think that giving chemotherapy in the later line doesn't necessarily get easier than giving it up front. Up front, we usually give it 6 cycles and then move on, or just continue with the hormonal therapy. We don't try to give more than that. At least I don't typically. So, I think for patients, so while we don't know who needs the docetaxel, if there are patients that you think are going to need chemotherapy at some point in their course, I think it makes sense to consider giving it upfront, especially with these data that are kind of reassuring in terms of safety, with layering on the different therapies and adding in ADT plus chemo plus a new hormonal agent. So that's ARASENS. And this is really the one study that I think is practice changing, although we already have ABI plus docetaxel after piece 1, but kind of confirming that that strategy for those with aggressive metastatic hormone-sensitive prostate cancer. So up next, PROpel and MAGNITUDE. So PROpel is the AstraZeneca study, abiraterone plus olaparib or placebo for first-line metastatic CRPC. Docetaxel was allowed for the hormone-sensitive setting, no prior ABI. Other agents like enza, apalutamide were allowed if they were stopped more than 12 months prior to enrollment, so effectively not really allowed. So it's mostly for patients who progressed to CRPC on ADT alone, may also have had chemo earlier on. It basically took all comers and then retrospectively did the genetic analysis to see who had homologous recombination repair mutations. And so the stratification was by site of distant metastases, bone only versus visceral versus other, and then prior taxane. And then randomized 1-to-1 ABI plus olaparib, ABI plus placebo. The primary endpoint was radiographic progression-free survival by investigator assessment. Overall survival being a key secondary endpoint, of course. So this is PROpel, and this is MAGNITUDE, also first-line metastatic CRPC, also abiraterone as the backbone, plus either placebo or niraparib as the PARP inhibitor in this example, or in this study. They did testing up front and then randomized or sort of assigned people to cohort based on the biomarker status. And so here's their biomarker panel. And then you're either assigned to the biomarker negative cohort, so kind of one phase 3 study for biomarker negative, or to the biomarker positive cohort, so almost kind of an independent study for those that were biomarker positive. Because they did this testing up front, they did also allow for up to 4 months of ABI. So you could get started on the abiraterone for CRPC while you were undergoing the testing, and then you had to get started on the niraparib or placebo within 4 months of that. They also allowed for prior AR pathway inhibitors for non-metastatic CRPC or for in the metastatic hormone-sensitive setting. Although in reality, the percentage of these patients that had these kinds of therapies was pretty low. And then they also stratified by BRCA1 and 2 versus other within the biomarker positive cohort. And they also set a threshold for BRCA1 and 2 in that within the biomarker positive cohort, they had to have at least 50% of their patients have a mutation in BRCA1 or 2. But it's a first-line CRPC study. It's abiraterone is the backbone, plus or minus a PARP inhibitor. Radiographic progression-free survival is the primary endpoint. Overall survival is a secondary endpoint. So the biomarker negative group, early on, there was an initial evaluation and a composite progression endpoint, radiographic or PSA progression. In fact, the hazard ratio was like 1.09 or something. And so this cohort of the study was stopped early for futility. And so the rest of the presentation and the rest of the study all focused on this biomarker positive cohort. So here's the data: radiographic progression-free survival by central review, all biomarker positive on the left, and the BRCA1 and 2 cohort on the right. So this was a positive study in all comers, although the hazard ratio was higher than 0.7. And that's, 0.7 is really where I like to see things land if I think that they're worth thinking about bringing into the clinic. But it's positive with a p-value of 0.02. And not surprisingly, more positive when you restrict it to just the BRCA1 and 2 cohort, hazard ratio 0.53. And here, looking at the absolute benefit in terms of time or months, there's about 3 months versus about 6 months or so improvement in radiographic progression-free survival. Going back to PROpel now, switching back to the olaparib study. This is the radiographic progression-free survival, although this is investigator read progression-free survival, and the intention to treat population, so biomarker positive and negative. And this is a positive study overall with a hazard ratio of 0.66, highly significant, a very low p-value here. And I guess we're not, here we go. With improvement in time, the radiographic progression-free survival from 16 months to 24 months, so a 8-month improvement here. We did not see Kaplan-Meier curves for the subset for homologous, for biomarker positive or negative, but we did see the forest plots, and you probably can't see this, but the hazard ratio for the homologous recombination repair mutated is 0.5, and the hazard ratio for the non-HRR mutated is 0.76. So that's not all comers. All comers is 0.66, and those that are homologous recombination repair mutated is 0.50. And even if you didn't have any mutation, 0.76. What I don't know is if this includes those for whom they weren't able to get a result, because of course they took all comers and then looked at the mutation status retrospectively. Presumably some of these patients, the sequencing failed and they didn't have a result. And I'm not sure about that information. So some comments. Well, first of all, this generated a lot of controversy. We think of PARP inhibitors as kind of having a class effect. Niraparib was clearly negative in the biomarker negative cohort. PROpel is clearly positive overall. Again, our hazard ratio is 0.66. So even better than MAGNITUDE in the all biomarker positive group. There is a lot more difference in terms of absolute improvement in months for radiographic progression-free survival with 8 months. And these numbers, like the control arm here, looks like the experimental arm in MAGNITUDE, although some of that may be explained by the fact that patients in MAGNITUDE could get started on abiraterone for 4 months before being randomized and starting the niraparib. And it was at randomization that they started the clock. And so you could probably tack on some months to what we see in MAGNITUDE. And so there's a lot of discussion. There are clearly differences. So MAGNITUDE also allowed prior AR pathway inhibitor, although those numbers were pretty small in the single-digit percentages. but a little bit more open eligibility. So what's the reason for these differences? Is it drug? Is it trial design? Is it something else? And I think it's still kind of an open question. But I think we can say that PARP inhibitor and abiraterone does prolong radiographic progression-free survival versus abiraterone alone, certainly in patients with homologous recombination repair mutations. So that was positive in both PROpel and MAGNITUDE, the biomarker positive. It does seem that olaparib appears to have benefit in a broader population, with the overall trial being positive and including a hazard ratio of 0.76, which excluded in the confidence intervals excluded 1 in those that were biomarker negative. So questions, is concurrent better than sequential? And we don't really have that much information about what other people got at the end of the study when they progressed. Certainly in the biomarker positive group, you'd want to know if those in the control arm went on to get a PARP inhibitor or not. I think we want to know what overall survival looks like, and this may be also interesting for those in PROpel. So with olaparib and the biomarker negative, is olaparib actually improving overall survival in those that don't have DNA repair mutations? I think that will be especially interesting to see. My guess is no, since that hazard ratio was only 0.76. But we shall see. These studies aren't published. We're still looking for more information, like in PROpel, in those that are homologous recombination repair mutated. I do think of BRCA2 as being by far as being the strongest predictor of benefit from a PARP inhibitor. So how much of that benefit? So the hazard ratio for the biomarker positive in PROpel was 0.50. That's all comers with homologous recombination repair mutations. What percentage of those patients were BRCA2 mutated? In PROfound, I kind of feel like it was the high percentage of BRCA2 that kind of carried the load of all the other DNA repair mutations. I think there are others that do respond to PARP inhibitors pretty well, but certainly not all of the 14 genes that we think of as being kind of DNA repair gene mutations. And so to what degree is the excellent hazard ratio and the biomarker positive, how much is that driven by BRCA2? And then, was it the trial design, or is it the drug that's contributing to these changes or to these differences between these studies? Is less PARP trapping actually better? So, there's a class of drugs. Veliparib is kind of on one end with less PARP trapping, then olaparib, then niraparib, and then talazoparib. And so you may think talazoparib, the more PARP trapping, it may be the strongest drug and it may have the strongest effects. Well, it wasn't presented here, but niraparib is kind of next in line. But that was a study that had kind of the less impressive results. And I didn't really show you the toxicity, but it did have a little bit worse toxicity. Again, it's sort of comparing different studies, and maybe there are reasons for that, that they were reported differently in one study versus the other. Niraparib was also given at a little bit lower dose than what you would think of for monotherapy, for niraparib monotherapy. And niraparib is often used in the ovarian cancer setting, and I think there are a lot of dose reductions there. And so maybe the dose that was used in MAGNITUDE is actually a sort of a functional dose that's often used in the real world. I don't know. Maybe it's a dosing issue. Maybe it's maybe there actually is drug differences, and for some reason olaparib is better than niraparib. I think so. My conclusions are, I guess, that the data with olaparib does look better. I think, thinking about olaparib and rucaparib, which were approved by the FDA sort of within a few days of each other. So there, in the later line setting, olaparib data looks more impressive than rucaparib. So I think olaparib seems to be the drug to beat, and I think, for patients with BRCA1 and 2, there are 2 studies that show pretty significant benefit of using it early on, but I'm not totally convinced that concurrent is better than sequential. I'm really looking for that data. If there are patients that with BRCA1 and 2 mutations where you're looking for a dramatic response or pretty symptomatic, I think it's certainly reasonable to consider it, and I would go with olaparib, I think, at this point. But in terms of implementing this more broadly, I think I am still waiting for some of the additional data to come out. So that's my hedging answer on that, I guess.
Dr. VanderWeele,
I have a comment.
I think Dr. Shaver had a question. Yeah, go ahead.
Oh, yeah. I mean, there is, though, basic science biologic data, though, David, right? That even in a mutationally intact person, that there's synergy between AR inhibition and PARP inhibition, right?
Yeah.
I mean, so it's not like the reason that PROpel was designed the way it was because there was a rational amount of data from basic science that suggested that there would be a synergistic effect. And so that would be my one comment. And the second comment is I always kind of look at the control arms of these groups, right? And as you, I think, mentioned in PROpel, the control arm in PROpel behaved identically to the registration trials for ABI for in this space, right? The median survival or progression-free survival was like 16 months, I think, in the Cougar trial, and it was that way in PROpel, right?
Yep.
So that seems sensical. And then I thought that if you added 4 months back in to the magnitude, that actually those control arms behaved pretty similar. Maybe not quite as good, but pretty similar, not as disparate as it initially appears at first blush. Is that also your sense, David?
Yeah, I think so. I don't know what percent of patients were on ABI for 4 months. That's kind of what was allowed, and I'm not sure kind of what the typical delay to starting the niraparib was, but yeah, I agree. I think the arms, at least in terms of the timelines, they first appear to be more disparate than they are. Although the separation of the curves, I think, is, I mean, we haven't seen the curves broken down for PROpel, but just the hazard ratios presented. But I guess that the hazard ratios still seem more impressive for olaparib. I guess I would say significantly compared to niraparib.
Yeah, I agree.
But to get back to your earlier point, absolutely, there's a rationale. There's a biological rationale. So, hormone therapy can lead to increased DNA strand breaks, sort of sensitizing to a PARP inhibitor. And PARP inhibitor may have some signaling that actually is additive or synergistic with AR inhibition. So there's biological rationale both ways. And in addition, I didn't show it for the interest of time, but Noah Clark's study, I believe is Noah Clark's study, in late line CRPC, abiraterone and olaparib was an all-comer study. And they were surprised, well, I was surprised, and maybe the investigators were too, that they did see significant benefit in those that were biomarker negative in that study as well. So it does seem to be a consistent trend.
Yeah, I thought the only other thing I would comment on, if I'm allowed to comment, would be that, like in Profound, I was very disappointed that in Magnitude they did not show the BRCA versus the other mutations. They just showed all comers, right, with mutations, which is clearly being driven by the BRCA2 patients. And then they showed the BRCA1, BRCA2 patients, right?
Yeah.
So there's an opportunity to, again, kind of clear the water about, well, what really is happening in the non-BRCA1, non-BRCA2 patients with these agents. And they had an opportunity. They have the data. They just chose to bundle it, which I find, slightly frustrating, right? It's disappointing, I guess, would be a better way to describe it.
And not only are they bundling it, but because they were testing up front, they could control to make sure that they had at least half their patients were BRCA1 and 2.
Yeah. So, like to see the data. It's been back calculated for PROfound, right? And in that study, again, there's a very strong signal in BRCA1, BRCA2, not so much in all the other components of that pathway. And I'm just be curious to see, but I don't think we'll probably see that data published in that way.
Yeah, probably not. And in fact, I would even say there's a strong signal in BRCA2. I have to go back and look at PROfound, but in other settings, I think it's with rucaparib too. Even within that, BRCA2 kind of stands out. Even beyond BRCA1.
Right, because I think in PROfound, I don't know if you remember, Ashley, that was 1, 2, and ATM were bundled together as Cohort A or something like that, right?
Yep.
So, but they never published Cohort B. They just published the whole cohort, which they could have done. So
yeah, we only saw A plus B.
Yeah, that's right.
All right. Then very quickly, sort of something from therapy. So this is lutetium-177, PSMA-617, a study from Australia where they've had access to this radioligand therapy much more than we have here in the States. This is a phase 2 study with a PSA response endpoint, if I'm not mistaken. But what was presented at GU ASCO was looking at imaging, thinking about imaging as being predictive or prognostic. Patients going on this study had to undergo both a PSMA PET scan and an FDG PET scan, and they were excluded if they had significant FDG positive but PSMA negative disease. But here they use that imaging to look at patients based on the SUV, so how bright the lesions were on the PSMA scan, or the tumor volume, so how much disease there was on the FDG scan. And actually they found that the PSMA imaging, if you had a SUV mean greater than 10, and that was about 30%, 35% of patients, somewhere in there, this was predictive benefit from the lutetium therapy. Whereas if you had FDG volume, high volume cancer, it's kind of a no-brainer, but high volume on FDG PET, which also was about 30% of patients, you did poorly no matter what you got. And so here's the data. Those patients with SUV greater than 10 are down here. They actually responded to Cabazi a bit better as well. Compared to those that had SUV mean less than 10, which are up top. And then I think this is PSA 50 responses that's shown in the boxes here and quantified, quantifying the waterfall plots that are up above. So this is SUV mean less than 10 up top, SUV mean greater than 10, and then here's less than 10 and greater than 10. And so if you had SUV mean greater than 10 and you got the lutetium PSMA, you had a 91% response rate in terms of PSA 50 response. That looks pretty good. So also responded better to cabazitaxel, but that's not nearly as dramatic as increasing from 52 to 91%. Whereas the FDG marker was prognostic, and so those that had a lower tumor volume, less than 200 mils, 56% had a response rate combining the two arms, whereas those that had a higher tumor volume, only 38% had a response. combining both cabazitaxel and lutetium. So, we've been stuck with bone scans and CT scans for a long time. It would be nice to get into an era where we can look at disease a little better, especially something that would show response in the bones. We're not there yet, but I'm interested in these sort of PET imaging studies and how we might utilize this information. So that was just a little aside from therapy. Now moving into,
before you go on,
yeah,
just a small thing, Dr. VanderWeele, maybe if I don't know if any of our radiologists are on the conference, but the one thing I thought when I saw that presented and from your presentation was, right now when people read these PET PSMAs, they've kind of decided from a radiology side point that it's not important to report the SUVs. So at least at our institution, we don't see standardly the SUVs reported with the scans. And I know that the lutetium PSMA hasn't yet become used in clinical practice, but it's near it. It's getting close. And so I wonder if we can encourage our radiologists and if Dr. Savas is not on, I might send her a note and CC you that let's get the SUV reads in, because maybe sooner than later this will guide some therapeutic choices.
Yeah, and a question that was asked. So we had the VISION study here open for a while, which was with lutetium-177, PSMA-617. We've sent folks to some other institutions that had a sort of expanded use protocol open. Before then, we get the PSMA PET scans to basically be making sure that the disease is lighting up and is PSMA positive. We are not getting the FDG scans. I don't know if that's necessary, and that was one of the questions that was asked. Should we be getting these scans to be informing our decisions? Do you need the FDG to go along with the PSMA PET to be identifying the disease, or can you just see that stuff is kind of PSMA negative on that PET scan? I don't know. I think I think there's still a lot to sort out here, but I think we're going to be making more use of and smarter use of these scans going forward. All right, moving into bladder. So again, 2 studies on antibody drug conjugates. First one is EV-103. So this is a kind of a sprawling clinical trial with many different cohorts. Here is cohort H, all the way up to H. And so this is for neoadjuvant enfortumab vedotin, basically for patients node negative and cisplatin ineligible and in the bladder. They did allow other histologies, variants, as long as it was at least 50% urothelial. And then, planning to undergo cystectomy. So neoadjuvant EV for 3 cycles. And here it's shortened. So typically we're giving EV on a 28-day cycle, giving it on day 1, 8, and 15. But here it was 3 21-day cycles, and repeat imaging and radical cystectomy and lymph node dissection. So small trial, only 22 patients, good performance status. Most patients were clinical T2. Again, you had to be transitional cell or urothelial, but they did allow some other differentiation, including squamous and other mixed in there, as long as it was mostly transitional cell. Importantly, most patients got most of the therapy. The time from the end of therapy to surgery was a median of 1.8 months with a long range of 2.7 months. And they claim that there were 0 cases where surgery was not performed or was delayed due to adverse events. And then really what we're looking at is pathologic responses. What we're interested in is the endpoint, because we think this predicts good outcome longer term. And so their pathologic complete response rate is 36%, and downstaging rate is 50%. So that really compares pretty nicely with what we see with cisplatin, cisplatin, gemcitabine. Typically, we're in the 35 to 40% range. With dose-dense MVAC or MVAC, you maybe can get up into the low 40s, but for a small trial, it's kind of hitting right where you'd want it to. They show the EV is safe, at least in this relatively small cohort, no surgery delays. So some questions coming out of this, should there be biomarker selection? So, Dr. Meeks has been involved and others with looking at different sort of molecular subtypes. Enfortumab vedotin is MMAE payload on an anti-Nectin-4 antibody. That's the antibody drug conjugate. Nectin-4 testing for Nectin-4 expression is not required and really not done in practice typically in the metastatic setting. But there is some data that Nectin-4 expression may be higher in the luminal subtype. So could you get even better responses with biomarker selection? And so, I think this is a nice study. It's a single agent, but the folks developing EV at Seattle Genetics, and I'm forgetting their partner, I think are really looking at, in addition to other settings, are really looking at a lot of combination studies, especially because there's been really encouraging data from EV plus Pembro in the metastatic setting. But they got their hands in many pots, including EV plus Pembro compared to GemCis, EV plus Pembro versus Pembro and those that are not cisplatin eligible, and then EV plus durvalumab versus EV plus durvalumab plus tremelimumab, so PD-1 inhibitor and CTLA-4 inhibitor. And these are all ongoing neoadjuvant studies, so I suspect EV monotherapy is probably not where we're going to end up, probably EV plus some immunotherapy partner. Stay tuned for more data. So the other antibody drug conjugate is sacituzumab govitecan. So this is SM38 payload. It's essentially irinotecan on a TROP2, anti-TROP2 antibody. That's the sacituzumab. This is approved for bladder cancer as well as for breast cancer. Trophy U01 is also kind of a sprawling trial with many different cohorts. What was presented here is cohort 3, which is sacituzumab govitecan plus Pembro for those who progress after prior platinum-based therapy. And they're looking at objective response rates. Cohort 1 is really what led to the approval of sacituzumab. This is about 100 patients who had progressed on prior platinum and on a checkpoint inhibitor. So now you're kind of moving things up or taking sacituzumab from the later line, moving it up to combine it with the immunotherapy in the second line setting. I think functionally for me right now, sacituzumab is kind of fourth line therapy with cisplatin or platinum agent, and then immunotherapy, and then enfortumab vedotin, and then sacituzumab functionally. So they're kind of leapfrogging, trying to get to an earlier space is kind of my interpretation of this. So here's the waterfall plot of responses. Objective response rate is 34%. Again, it's a small trial, only 41 patients, 14 responses, CR plus PR, in 14 patients, or 34%. In some patients with some pretty significant responses, I guess one is listed as a CR, but some pretty deep responses. Looking at the patients that were enrolled in the study, there are some that have visceral metastases, including 12 patients, And the response rates with those with visceral metastases was pretty good, 41%, so at least as good as the overall. And then here's the swimmer's plot of the duration of those responses. In general, the median duration was about 5.5 months or so. But for those with responses who are in light green, the duration of response is not yet reached. This is looking at the safety, and so this is, I was thinking this is grade 3 responses. Yeah, here we go. Treatment-related grade 3 to 4 AEs, 59% of patients. That's not really a small number. 39% had dose reductions and the sacituzumab due to adverse events. So not a benign treatment. So conclusions and questions. Overall response rate, 34%, that's okay. But sacituzumab alone in the immunotherapy setting has a response rate of 27%. And if we're thinking about, antibody drug conjugates and immunotherapy, EV plus Pembro made a big splash a year ago or so. I forget exactly which meeting that was. With overall response rate is 73%. But of course, that was not in pre-treated patients. That was a first-line setting. So not really comparable, but we'd hope for maybe for something a little bit higher than that. And there are numerous trials with antibody drug conjugates that are coming, including actually combining EV and sacituzumab, the DAD trial, or double antibody drug conjugate study. So questions, how long does this duration of response go? Even if the response rate is not great, if we get really durable responses, that may make this data more interesting. And then again, so sacituzumab is being combined with many other agents, with cisplatin plus avelumab, or as I said, with enfortumab vedotin. So you're looking out for those results as well. All right, finally, a few minutes left, wrapping up with kidney and really just highlighting one study here. This is looking at neoadjuvant therapy with avelumab and axitinib. So this is kind of the rationale. There have been studies with neoadjuvant axitinib alone, generally smaller studies. Response rates generally around 30%, in the 30s, let's say. Axitinib is a TKI with a shorter half-life, and so it kind of lends itself to neoadjuvant therapy where you're not as concerned about wound healing afterwards, and there's a quicker washout. And of course, everybody's trying to combine things with immunotherapy. So here's the study design. Basically, patients with relatively high-risk clear cell RCC. You do 3 cycles, re-image, and then do 3 more cycles, 2-week cycles. So 6 to 12 weeks of therapy. If there was concern for progression, patients could come off early and undergo surgery. And actually, some patients, one patient did come off early because they thought there was progression that turned out to be a hematoma. And then here, so you see surgery not earlier than 36 hours after the last axitinib. So it's much quicker washout than, say, like with Cabo or something where, these half-lives are in days. So here's the baseline of who was enrolled. A lot of patients were T3A, although some patients N1 as well. A lot of patients maybe higher than expected with grade group 1 to 2, or grade 1 to 2, in terms of who's getting this sort of neoadjuvant therapy. And here is the waterfall and kind of a spider plot of tumor responses at 6 weeks and at 12 weeks. And be mindful that this waterfall plot doesn't go down to 0, it goes down to -50. And so here's RECIST response cutoff at 30%. And so overall response rate reaching that 30% cutoff is 30% of patients. No progressions in the primary tumor. The one patient did develop liver metastasis on imaging, and I forget if that was at 6 weeks or 12 weeks. And the median downsizing was about 20% or so. And not surprisingly, those who had a response did better in the long term than those who did not have a response. So there are no new safety signals. One patient had a delay in surgery for 3 weeks. One patient developed a liver met. In general, so the 30% response rate is similar to what was seen with axitinib alone. So you're not really improving your response rate with by adding in the immunotherapy. Is there a role for this kind of a strategy? I think there could be a role for people with kind of borderline resectable disease, or if there is a delay for surgery for some reason, like a comorbidity, an acute comorbidity that you need to get over or something prior to having undergoing nephrectomy. I think there could be a role for axitinib. I don't know that there is a role for the immunotherapy. There are other immunotherapy alone sort of perioperative studies or neoadjuvant and adjuvant that maybe can answer better the role for the immunotherapy component. Maybe we'll get a little bit more data as they follow these patients a bit longer.
Yeah.
Yeah, go ahead.
Actually, honestly, clinically, it's a terrible study. But, just to get to the meat. On the other hand, I think there's really a lot of interest in neoadjuvant, in part to study the biology. And truthfully, the big study that just finished accrual from ECOG, is looking, at only at a one cycle, which you can say is not enough. But I think there's the 30%. I'm not even sure what to do with, and it's not an attractive regimen. I mean, I don't know anybody who uses avelumab and axitinib. I guess it's fine, but I think the only use of it is really to get biologic data, and certainly that can be really helpful. But there's no way to tell whether it's doing anything in terms of ultimate outcome.
Yeah, and there was some biomarker data presented as well, but it's biomarker, well, it's sort of looking at the tissue of the responders versus the non-responders. It's not a predictive biomarker going into the therapy, but
and there is some great biomarker stuff being done in renal cancer. I mean, really some nice molecular work. I'm not sure how these people fit into it, but certainly people out east have done some really nice stuff.
Yeah. So, just the last question, will neoadjuvant beat out adjuvant therapy? And so there was also an update of Keynote 564, which basically said that with additional follow-up, the data continues to look good. Look at the separation of these curves. So this is T2, T3, T2 sarcomatoid or grade 4. High risk was T4 or nodal involvement, and then the M1, which is a pretty small group within the cohort, but clear separation of these curves. So I think how this fits in clinically, don't know, but will continue to be useful, as Jeff pointed out, with thinking more about the biology. And that is it So thank you for those who are still on, and happy to have more discussion or comments if there's any more to be said.
Thanks a lot,
David. That was spectacular. Thank you so much.
So David, now I understand why you don't want to do renal cancer. It was actually really sad how little there was. You know, I think everybody felt that. You know, because really the update was the main thing, the update of 564. I'm not sure, you know, there were a couple, I think Mike Atkins' study, which we were part of, but, you know, there are a couple studies that have shown that giving single agent followed by combination is not a good idea. You don't seem to get a great benefit from combination, and many people don't even go to combination. So I think that study proved that, which is too bad, but at least it did look at that.
Yeah, I mean it's cyclical, right? I mean, yeah, this year turned out to have all the exciting data in prostate, I think.
Oh, you're right. Absolutely. Yeah. No, it was a down year, but the prostate that was why to go to the meeting, not for the renal cancer. So
when Jeff is paying attention to prostate, you know.
Yeah.
That will be the end of me.
Yes.
No, I think you definitely don't need me. You got a great group, and we can talk more about kidney offline. Take care. Thanks a lot, Dave.
Thanks.
Yeah, thanks again, Dr. VanderWeele. Thanks, everybody. We're at the bottom of the hour. We'll see everyone next month. Thanks so much.